Okay,
Mm.
great. And again, I am Diane Christian with the Partners for Pediatric Vision. We are here with Dr. Rosales, who's going to be talking to us about your child's vision. And again, this is for educational purposes only. I would like everyone to kind of go around and just introduce themselves. Janice, would you like to go next?
My name is Janice Goldhaber. I'm a licensed marriage and family therapist. I've worked in the low vision field for most of my career, and I am partially sighted from retinitis from uh, ROP. Can't remember my
Oh,
diagnosis. I'm tired,
okay.
and I'm very happy to be here.
Heather?
Hi, I'm Heather Dawson. I am a family specialist with Partners for Pediatric Vision, and then I have a 4.5-year-old with optic nerve hypoplasia.
Mm.
Rosanna?
Hi, my name is Rosanna, and I am the lead family specialist here with Partners for Pediatric Vision.
Zia Mara, can you unmute and just introduce yourself real quick? Which is
Sorry,
hard.
I'm currently at McDonald's, but hi, my name is Simara. My son's name is Isaac Rosinos, and he has optic nerve hypoplasia.
Perfect, thank you. And Yuki, would you like to unmute and just say hello and introduce yourself? Or not, but I think Yuki was the one that had the question about myopia.
Okay.
So there we are. Let me go ahead and we'll start the PowerPoint. And everyone, I'd like to introduce you to Dr. Teresa Rosales. She's a retired pediatric ophthalmologist. You worked in Long Beach, serving the Southern California area for just a couple of years, right? No, I'm just kidding. For many years. And then just in terms of just being a resource for our families have been really great. All right, let me
Thank
go
you.
ahead and share my screen. And okay, does that look okay with everybody? Thumbs up?
Mhm.
Okay.
Now, so Diane, will I be able to change the slides or is that
It's going to be me, so just let
okay?
me know. So
Okay.
I have on here the importance of eye exams, and I'm not sure if you wanted to touch on this before we get into it.
Okay. Well, pediatric vision exams are important even if your child doesn't have a vision problem, because this young child doesn't know the difference and won't know if there's a problem with their vision or not. The Pediatric Society recommends that their vision exam or checking the visual acuity and binocularity be done on a regular basis when the children come in for their annual exams. The idea is to try to pick up problems early rather than waiting until things start to get serious and may not be able to be treated. So the earlier you pick things up, the better. We're looking for refractive error, meaning that they need glasses. We're looking for amblyopia, which means poor vision in one eye versus the other. We're looking for serious problems like retinoblastoma, where the pediatrician would see a white reflex in one eye instead of the red reflex. Um, so they're looking for abnormal eye movements or poor alignment of the eyes. So your pediatrician is the first person who's going to be seeing the child and would probably make the diagnosis that something is going on. And then again, starting ideally before kindergarten, having just a baseline eye exam, especially if there's a family history of being nearsighted and needing glasses, or a family history of eye muscle problems, which is strabismus, where the eyes are not straight. Family history of retinitis pigmentosa or retinoblastoma, and that sort of thing. So any family history of eye problems, the child should be seen at an early age. And even when the children aren't verbal or they're too young to read the eye chart, we can still test to see whether their behavior is normal or not for their age. So getting an eye exam early is extremely important, and especially if you have a family history.
The next slide is just the anatomy of the
The
eye.
anatomy. So For today's talk, since we're focusing a lot on prescription, whether your child needs glasses or not, what the prescription means, the important part is the cornea. And I don't know if you can see my cursor, but on the top it says cornea. And then the clear part in front of the eye is the cornea. And then behind that is what we call the anterior chamber. That's in front of the pupil. The iris, of course, is the colored part. And the pupil is an opening in the iris. Behind that is the lens. And then behind that, for those of you who have children with optic nerve hypoplasia, the optic nerve is way there in the back of the eye. And when the eye doctor does the exam, they look through the pupil into the back of the eye to take a look at the optic nerve and also the retina, which is the lining on the inside of the back of the eye. So all of those are important parts. But for our talk, or most of what we're going to focus on today is the need for glasses and why we check children for glasses. And so the cornea and the actual length of the eye are very important in determining what the prescription is. And there are certain instruments that your eye doctor will use to determine the prescription that your child has. Many parents say, well, how can you tell if my child needs glasses? And that's a good question. It's actually really easy for an eye doctor, but most of the time they will dilate your child's pupils. They'll put drops in that will dilate the pupil. The drops are, they sting a little bit, but after the child blinks a couple times, they don't sting anymore. The purpose of dilating the pupil is that we want an accurate prescription. If the pupil's not dilated in a child, we can't tell where they're looking, what they're focusing on. And what they focus on will change the prescription. So by putting the drops in, they can't focus for a little while, and that makes it much more accurate. When adults go to the eye doctor, they look inside a machine, and the machine does what we do manually and figures out what the prescription is. But for children, we use a handheld instrument called a lensometer, and we hold up loose lenses or lenses on a bar, and we can figure out what the prescription is fairly accurately. We can tell if they're nearsighted, farsighted, and whether they have astigmatism or not. And so that's a lot of what we're going to be talking about today. So we can go on to the next slide. Okay, so myopia. Myopia means that the eye is effectively too large, that here we go. So the focal point, the point where things are clear, instead of being on the center of vision, on the macula, it's focusing in front of the retina. And the only way to get that image clear is to hold things up very close. So that's where the term nearsighted comes from. The correct term is myopia. And in order to treat that, you need glasses. You need glasses for distance. Many adults will take their glasses off to read because what we call the far point, the furthest point away where things are clear, is up close. But for kids, and you need to be able to see the board in school. You need to be able to see across the room. And so if a child's significantly nearsighted, then glasses would be indicated. Myopia can be hereditary, and we think it might be autosomal dominant, so it's a strong hereditary pattern. If your parents are nearsighted, there's a good chance that half of the kids are going to be nearsighted as well. But it also occurs with different disorders like retinopathy of prematurity. Many children with ROP are nearsighted. The smaller the baby, the sicker the baby, if they have severe retinopathy of prematurity, if they needed to be treated with laser or now with injections, all of those increase the risk for a premature infant to have myopia. And often it's high myopia, and it often occurs much earlier than in the general population. And myopia tends to be progressive. It tends to get worse as the child grows, because as they grow, the eye gets longer, it gets bigger. And so that original prescription that could get the focal point, the sharpness on the retina, as the eye gets larger, then it no longer focuses on the retina again. And so you need a stronger prescription. And in the general population, myopia tends to show up between ages 8 and 10, gets progressively worse. In boys, they can keep on changing through college. The girls tend to stop growing, and so their prescription stops changing more like high school or early college. So those are general tendencies, but myopia does tend to get worse. As adults, the LASIK surgery is an option to treat the myopia, but in children, that's not an option, and so glasses are the treatment of choice.
When is like laser surgery or LASIK recommended, after 18 or something?
Well, age plus is the prescription still changing? So again, for the young adult boys or men, often their prescription continues changing as they keep on growing into college. So the prescription has to be stable, and they have to ideally over 18.
Okay.
I'm sure there's some leeway there, but mainly you want a stable prescription. You don't want to go through that procedure and then have the prescription continue to change after they've already had the LASIK surgery. So yeah, it's usually something for college age or older. And having said that, my oldest daughter did have LASIK surgery. She was a preemie also. My husband and I only need the glasses for reading. So in her case, I think it was probably because she was a preemie and ended up with a fairly significant prescription.
Can I ask a question? I was wondering if a child's eyes have more eye pathology because of the diagnosis, then I'm assuming that LASIK would not be a possibility, and also that might change what you're looking at as the child gets older.
Good questions. So, especially with ROP, retinopathy of prematurity, there's a lot of pathology going on there, or there can be. The earlier the baby is born, the smaller the birth weight, and how sick the child is all contribute towards the retinopathy of prematurity and the severity of it. So, LASIK is not. LASIK can be an option depending on the LASIK surgery will not improve the vision any better than glasses will. Let me put it that way. So if glasses correct the child to 20/20 or 20/30, the laser surgery will only be able to get them to 20/30 if that's their best correction. So it's not better than glasses, but it certainly can be more convenient, especially with high prescriptions. Those glasses tend to be really thick. Contact lenses are also an option for kids with high prescription, but usually we don't start contacts until they're middle school, if the child's going to do it themselves, because they have to have good hand washing technique. They have to understand that wearing the contacts, it's not something they can just take out and rinse off with tap water. There's a strict regimen for cleaning and taking care of contact lenses. And so if the child's going to do it themselves, they really need to be old enough to follow the directions correctly, because there's a risk of using contacts if they're not taken care of properly. There are other diseases like Stickler syndrome that's associated with high myopia. And there's some retinitis pigmentosa syndromes that are associated with high myopia as well. So it's not just hereditary, it can be part of another syndrome also. So I think we can go on to the next slide.
I wasn't sure where you wanted this slide at,
So this is showing that the top figure is showing that the focal point here is in front of the retina, And so this is a patient with myopia, and then putting this is a minus glasses in front. Now it gets the focal point onto the back of the eye, onto the macula, so that you have a clear vision. So that's just a schematic drawing of what the other slides are showing. Okay, so hyperopia is the more normal state for most children. This is okay. So
or this one.
yeah, let's start. No, that's astigmatism. So let's go back. Let's go back one more slide, I think. Yeah. So
This one
no,
or this one?
right there, right there. Okay.
Okay.
So hyperopia, most children, if they're not preemies, most kids are farsighted. And that's the common name for hyperopia, which is a technical term. Because children have a tremendous ability to focus, it's usually not a problem. They see fine for distance, they see fine for near, and they can see just fine. They don't need glasses. If the prescription is extremely strong, then it's really hard for them to focus adequately to get the image sharp on the back of the eye. And that's when glasses may be indicated for kids who are farsighted. The other situation is if when we focus to try to see something clearly, our eyes tend to converge a little bit. If you have to work really hard to focus to see clearly when they're farsighted, then it can cause an overcompensation of that convergence and they can start to cross. So that's another indication of children needing glasses, one, to see better, but mainly to keep their eyes straight. And the good news is that many of these kids outgrow the prescription as they get older because their eye gets bigger and they don't have to work so hard to focus to get the image clear on the retina. And so they tend to outgrow their glasses. So when you're farsighted, very often the prescription gets better over time. And many of these kids outgrow their glasses. Not everyone, however. So there are still some young adults who need their glasses or contacts to keep their eyes straight. So usually we don't operate on kids, especially if they're straight with their glasses on, we don't recommend surgery because things change as they get older and they may outgrow the glasses completely. So let's go on to the next picture. And this shows saying that the eye is too short is a little simplistic. Basically, the image is focusing behind the back of the eye, but when you focus using the lens of your own eye, you can bring the image to a sharp point on the retina itself. And so these kids can compensate just fine without any glasses most of the time. And I did have a couple of young adults who were very unhappy that their eyes still crossed in their 20s. And there now is a LASIK procedure, a laser procedure for people who are farsighted as well. But again, that's not until they're adults and their prescription is stable. Okay, we can go on to the next slide then. So astigmatism is a little more complicated. It means that the front of the eye, the cornea that I showed you earlier, isn't completely round. So the cornea is irregular. And what they're showing in this bottom picture is that the images, it's saying multiple focal points, so that everything's blurred and pretty much all the time, unless you have glasses on. So significant astigmatism is a reason for glasses as well. And I wanted to talk about, there was a question about this prescription. And unfortunately, I don't think that parent is here. But there was a question about the discrepancy or the difference between the way optometrists write the prescription and the way ophthalmologists do. And the bottom line is, oh, there you are. Okay. The bottom line is it's math. It's just, so So I'm looking at the prescription that you sent in, and it says plus 175. That part just by itself would tell me that this child was farsighted. The plus means they're farsighted. The next part, the cylinder, is the astigmatism. And the astigmatism is written in minus cylinder. It has a minus sign in front of it. So that's a moderate to fairly significant amount of astigmatism. And that would cause a significant amount of blur in this child. What we worry about in the young children is if they have a high prescription that they would be struggling to see clearly, they can end up what's called bilateral amblyopia. If the image is always blurred on the retina and it's not a clear image, no matter where they're looking, then the brain doesn't recognize, it's not getting a clear image. And so it's not those brain pathways aren't going to develop properly, and they can develop what's called bilateral amblyopia. Normally, we think of amblyopia as being one eye that doesn't see as well as the other. But a significant prescription can cause amblyopia in both eyes. So this child has a moderate amount of astigmatism, enough that it would cause a blur all the time. I'm not sure that I would put the child in glasses as an infant or a toddler, but by preschool and kindergarten, this would be enough of a prescription to make it difficult for the child to see things clearly and to perform well in school. Now, one of the questions was, well, one doctor said the child was farsighted, and another doctor said the child was nearsighted. Depends on how you write the prescription. So this is written in minus cylinder. The minus sign is in front of, underneath the column where it says cylinder. And so you would say, well, this kid's farsighted, but I can flip it and make it in plus cylinder, and then it would look like the child was nearsighted. So that's not really the issue, whether it's nearsighted or farsighted. The issue here, and the reason the glasses were recommended, is because of astigmatism. And it's a moderate amount, so that I'm not sure, I don't remember how old the child is. But it would be enough that I would want for preschool or kindergarten, I would probably want the child in glasses. Now, does a child need to wear glasses all the time? Okay, so mom's saying that one doctor, the ophthalmologist, said myopia and the optometrist said farsighted. Well, like I said, depends on how you write the prescription. And again, the main factor here is the astigmatism. Now, does she have to wear them all the time? No, but it's often easier to just say, you get dressed in the morning, the glasses go on, and we leave them on. Because if the child's allowed to take the glasses on and off, I don't know about you, but if I put my reading glasses down somewhere, uh, I will forget them. So you can't expect a 3 or 4-year-old to remember where they put their glasses and to put them back on again voluntarily. So it's probably better to just say, put the glasses on, leave them on, and okay, so mom says now she's almost 6. So yes, now I'm guessing that the child would really appreciate having the glasses on because she sees better with them on.
So I have a question then. How does the optician know how to make the glasses? Is it pretty apparent to them?
Yes.
Okay.
Yeah. Yeah. So either way, whether it's written in plus or minus cylinder, part of it depends on your training. Because I usually write it in minus cylinder, but I can go back and forth. And part of it depends on your machine. So if your machine's calibrated in plus cylinder, that's the way you're going to write the prescription. That's the way it'll print out. If it's calibrated in minus cylinder, it'll print it out the same way. I can get into the details on how to convert this. You take half of the cylinder, so the child that we're talking about had a 2.5 diopter cylinder. Half of that is 1.25. You add that algebraically to the sphere, and that comes out a +1/4 or +1/2. So, yeah,
It's all
it's
mathematical
just
then.
math. Yes, it's algebra. You do the same thing to the cylinder and you add it to the sphere. But it's the same prescription, and the optician will make it correctly, as long as they pay attention to the axis, the direction. So there are three parts to the prescription. There's the first part is whether it's plus or minus, whether you're nearsighted or farsighted. Second part is the astigmatism. And then the third part is the direction of the astigmatism. So if it's at 90 degrees, then it would, if the astigmatism is straight up and down or at a horizontal, it would be at 90 degrees or 180. This axis was off axis, and that just tells the optician how to grind the lens to correct for the astigmatism. So that's more technical stuff than anybody needed to know. But yes, it's not that one was wrong, it's how the prescription is written, and it's the same thing. It's just doing the math a little bit differently.
Thank you. That was very helpful.
Confusing, I'm sure.
And then the other question we get a lot in that you have reviewed was, parents will say, well, the optometrist said that my child's farsighted but doesn't need glasses. So I'm really glad that you reviewed that. That's typical for kids, and because
Yes.
it's within normal limits, they don't prescribe.
Yeah, so for farsightedness, we talk about the accommodative reserve that people have. By the time you hit 40, our accommodative reserve starts to go downhill. And so that's why the parents in this group, or maybe the grandparents for some of these, that's why we start needing reading glasses. And 40 seems to be that magic age, somewhere in there. We call it a latent hyperope. I never needed glasses until I was 38. And all of a sudden I couldn't read the fine print. So that's a little early. Most people are 40 to 45 before they start to need reading glasses. And your prescription for reading glasses, as most of us know, it gets stronger as we get older. Generally, for most of us, a +3 is as far as you need to go. Now, people who are visually impaired may need a higher prescription for reading, and can't usually find those at Costco. You can't usually find a higher prescription over the counter. You usually have to order those special order. For the kids, when they're farsighted, that gets better for the most part as they get older. And so most of the time the kids don't need glasses. But again, it depends on each child. So if they're in school and their prescription is still significant, so let's say 3, 4, or 5, even though their eyes may not be crossing, they're still working really hard to focus, to get that image focused on the back of the retina. And so glasses for school might be indicated. And then maybe running around and playing, they don't need them on. But again, it's easier to just leave them on and not let it be optional. Okay.
I think our next one is, you talked about amblyopia.
So yeah, we talked about it's mostly referring to one eye seeing better than the other. And if it's because of needing glasses, then if the prescription's different from one eye to the other, then we start with glasses, see how they do with the glasses on, and if the vision's improving, we stick with just the glasses for a while. Usually amblyopia needs to be treated with patching as well. Now, patching is our standard treatment. The kids hate it. The other option is to blur the vision in the better eye using dilating eye drops. Parents hate that. But one way or another, you have to get them to use the lazy eye, and we don't usually use that term, but parents use that a lot. We usually talk about the amblyopic eye, the eye that doesn't see as well. Somehow you have to give the better eye a break and make the child use the eye that's not working as well. And as long as there's no anatomical problem, like optic nerve hypoplasia or retinitis pigmentosa or Best disease or anything that's interfering with the visual acuity in the area of central vision in the macula, then they should be able to improve with patching and or glasses. And when I say patching, I include the eye drops as well. When you have, if the amblyop, even kids who have like optic nerve hypoplasia that's just in the one eye, we'll try patching at first to see what the best vision is that we can get in that eye. And then continue part-time patching just to maintain whatever the best vision is. We know that if there's a physical problem, the child's probably not going to have 20/20 vision, but if they could have 20/40 or 20/70, something functional, that would be worth trying to improve the vision with patching or glasses. The other problem with amblyopia is that they don't have good depth perception, so that makes it more difficult for ambulating, for sports and things like that. So we would like to have as good vision as possible in the amblyopic eye. They're not going to develop blindness. I don't agree with that line. And in general, yes, they may be legally blind in the amblyopic eye, but they're not going to lose total vision. And let's see. We don't use eye exercises for amblyopia, maybe for some other eye motor problems, but amblyopia is usually a brain problem. And so eye exercises per se don't really address that. So it's mainly figuring out some way to get them to use the vision in the other eye. Now, if the eye exercises are things where they're using one eye at a time and trying to improve binocular vision, that's a different story. But exercises per se won't help the amblyopia. But there's certainly treatments using colored filters or different kinds of glasses, things to try to get them. Now there's an amazing device. I can't remember what it's called because it wasn't something that was available when I was practicing, but it's like a visual reality headset, and it can project different images to each eye. And the idea is to try to use both eyes together to improve their binocularity. That looks very exciting. The one that I tried on at an ophthalmology convention was cumbersome, and they probably haven't improved the model since then, but it wasn't something that a young child would tolerate because it was fairly heavy and fairly big. But there was another one that they were looking at a screen, and somehow I think they had on red-green glasses, and then they could project. There were different images on the screen, and if they were using both eyes together, then they would see it in 3D. So there are newer technologies out there trying to either improve on the results from patching or to avoid patching, because patching, the kids hate the patch. A pirate patch is not acceptable. They just take it off and move it and put it in front of the bad eye. So, so that just isn't a good alternative. But these newer technologies sound interesting. They're not cheap, however, but hopefully as they improve things, the cost will come down and it'll be less cumbersome to use. The downside also is screen time. They're using screens. And of course, as parents, we're trying to get our kids off the screen and not on focusing on that all the time. So that's something that the parents have to figure out a way to make that work. But that's exciting new stuff that's coming out to treat amblyopia. Okay. So we can go on to the next slide, and we've kind of talked about this. Strabismus in this situation with refractive error would be what we call accommodative esotropia. Esotropia means the eye is going in, and accommodative because they have a strong prescription, they're very farsighted, and when they're trying to focus to see clearly, their eyes converge or their eye turns in. So accommodative esotropia can almost always be treated with glasses, sometimes with bifocal glasses. That's not real popular either, but that's another option. And usually that sort of problem can be treated with glasses alone. Okay, I think we've covered all the glasses questions. I don't know if the parents in the group had any other questions.
All right. Quiet today, aren't they? The next slide we have. Can I just let somebody in as well?
Yes,
Okay.
and I believe that was the mom that had the second question for the treatment of degenerative progressive high myopia.
Okay.
You want me to go back?
Sure, we can go back to myopia. Unfortunately, I don't have any magic. So we talked about how the myopia in general is progressive. As the children grow, their prescription does get worse. That there are some pathologies like Stickler syndrome where it gets worse and worse. The treatment right now is to just continue to increase the prescription in the glasses and or contacts and follow carefully. One of the risks with myopia, and we talked about my daughter, she was a minus 650. So even though she's had laser surgery and doesn't need glasses right now, she's now in her mid 40s and she's at high risk for retinal detachment and for glaucoma. So, and in a patient who has degenerative myopia, that's probably the major risk is retinal detachment. And so as a parent and working with your child, they need to be able to tell you, hopefully, if there's any change in their vision. If they complain that they see a curtain coming down over their vision, or if they're seeing spots or floaters, that's not normal in young children. And they need to get into the eye doctor right away. That's an indication that there's this floaters are red blood cells, and that's an indication that there's a break in the retina. And the curtain coming down is a sign of a retinal detachment. And so as a parent, you need to be listening for those kinds of complaints. And as the kids get older, they need to be aware that if there's any change like that, they need to let you know right away.
And there's an issue with timing with potential retinal detachment. So the sooner you get in.
Absolutely. Yeah, right away. It's critical. And when we tell adult patients, if you have a new onset of flashes and floaters, that gets you in. And most ophthalmologists will not make you wait a month or 2 weeks or whatever to come in. No, that usually gets you in right away. So yes, if your child comments, "Oh, I see flashing lights," not a good sign. You need to get them into the eye doctor right away.
Would you
And
suggest eye doctor or emergency room?
well, the emergency room is going to call the eye doctor. And if you have a doctor that you're established with, I would call their office. I would any of my kids who came in with that kind of a complaint, they would come in right away, we'd get them dilated and take a look to see what's going on. Emergency rooms don't use, unless it's a university or like a county hospital, they usually don't have an ophthalmologist on staff who's going to come in to see you. So they would basically tell you to call and make an appointment with your eye doctor. So I would call your eye doctor right away. And I'm guessing that most of your patients have somebody that they're affiliated with. In this case, it probably should be the ophthalmologist rather than the optometrist. The optometrist generally doesn't do retina surgery or the laser surgery that's needed to repair a break or a tear. So in this case, the ophthalmologist would be your better choice if you have one. If you don't, then call the optometrist first, and he usually will have a referral. He or she would have a referral to an ophthalmologist that he would work with. But yeah, new onset flashes and floaters and a new onset of shadow, or mostly patients talk about a curtain, that they have a loss of their visual field, basically. And that would be a really important thing to call about. There's been a lot of work looking at using low dose atropine to slow down the progression of myopia. And I'm a big fan of that. It was not available when my daughter was growing up and when she was in middle school and had to wear glasses and have braces. And middle school girls do not want to wear glasses. So we put her in contacts that younger than I usually would. But atropine wasn't available then. So atropine is a dilating drop, but when it's used in a very low dose, we don't know exactly why, it slows down the progression of the myopia. And it's been around forever and ever and ever. So the use of the eye drops, the medication itself, has been well studied and does not have any systemic side effects or problems. But it hasn't been used for nearsightedness or myopia for an extended period of time. I've been using it in my practice. That one of the doctors I worked with has done a lot of research on it. And so we've been using it for a long time. But the low dose, I don't know about now, but it had to be compounded, meaning that you couldn't just go to Walmart and buy 0.01% atropine or 0.02% atropine. It's not available on the shelves. So it had to be compounded, and not all compounding pharmacies have the ability to do eye drops. It's a special setup, special hood, and so not all compounding pharmacies can do it. When I've been out of practice now for 4 or 5 years, and at the time they were trying to get FDA approval for the low dose atropine for treating myopia so that we could start getting it made commercially rather than having to go through compounding pharmacies. I don't know the state of the art right now. I suspect you still have to go through a compounding pharmacy. So that would again be something that I think just ophthalmologists would have access to. I don't know about optometrists, so I can't speak to that. But we've seen really good results with the low dose atropine. You put 1 drop in every day at nighttime, and it works. Nothing's 100%, so it doesn't work all of the time. But if it can slow down the progression, that could potentially prevent the really high prescriptions and the patients who would then be at risk for retinal detachment and glaucoma. So it's exciting. It is now considered standard of care by the doctors. Haven't quite gotten the pharmaceutical company and the government on board with it yet. So it is something that's available. And so whoever would ask that question should ask their eye doctor about low dose atropine.
Great. Before we go on, does anyone have any questions about for Dr. Rosales? Yeah.
I have a resource that I used to help me put together some of these slides today. It's the APOS, American Association for Pediatric Ophthalmology and Strabismus, AAPOS. They have a public site for parents and patients, and it's written in not super technical terms. And I think that's a good resource to look for information if you have any questions on things.
And Rosanna just put it up on the in the chat. So
Oh, good. Thank you.
Elvira has a question.
Mm-hmm.
You want to unmute and ask?
Yes. Hi. Yes, my question is there certain accommodations for with kids with autism with the vision?
Accommodations in the classroom or
No, for
for
the with the eye doctor if they can't like speak.
Okay, so you may have missed at the beginning, I was saying that we don't, as a pediatric ophthalmologist, and I'm sure the pediatric optometrist as well, we can check a child's vision without them responding to us. We can check their prescription, even when they're nonverbal. We can check the prescription on a newborn because we're using handheld instruments and we're doing it objectively rather than subjectively, meaning we're not asking the child to respond. We're using the instruments to figure out the prescription on our own. So we can figure out the prescription even in a nonverbal child. Now, some kids with autism, and not just autistic children, may not be very cooperative. And so yes, it takes time. That's part of the challenge of being a pediatric, any pediatric specialty, is you have to figure out ways to work with kids who may be scared, who can't respond, who are not cooperative. I have a bag of toys that I would bring with me. Every time I go to the county hospital, I take the toys and give them to the residents. And they look at them and they're going, well, how do you make this work? I said, you push on the back and it spins. I mean, there's no batteries, there are no lights. It's just toys that get the kids' attention and they will track and follow it. The residents they use the phone and put movies on the phone and get the kids to look at that. So we've all got our bag of tricks on how to get the child's attention long enough to figure out what's going on. I teach the residents that don't touch the child, just sit back and observe. Start by holding the toys up and watching what they do. Once you touch the child's face, yeah, that could be the end of your exam. So get as much information as possible without getting too close. And most offices will have something at the end of the room, toys, or we used to have movies. Even the county hospital has a movie. It's not very exciting, but it gets their attention for a few minutes. And that's often all we need to find out what's going on, or at least to get an idea. If they're really uncooperative, then we will, sometimes what I've done is I've asked the parents to put the dilating drops in at home, and then they come in already dilated, so then I'm not the bad guy. And then I can do all the things I need to do with the retinoscope without having to get up really close, and can usually figure out what's going on. So yeah, it helps to go to somebody who's a pediatric specialist because we've got our tricks and our ways of getting the information we need. So
Thank
to that
you.
end, oh, you're welcome.
Sophia has a question, and I think she jumped on late, so we're going to refer her back to the recording once we post it.
Mhm.
So she also had a question about myopia and what's the effectiveness of spectacle lenses for slowing down the progression of myopia? And
The effectiveness of what for?
spectacle lenses.
Oh, spectacle of glasses, you mean? Spectacle lenses? Okay. For slowing down the progression?
Yeah. So she also puts my older daughter, 7 years old, just got diagnosed with myopia. She's too
Mhm.
scared of contact lenses and eye drops. So I chose the spectacle glasses for her. Her
Mhm.
prescription is mild, a -25 +50 in both eyes.
Ooh. Oh, I wouldn't even put her in glasses for that. Um, that's pretty low. Um, 7 to 8 or 8 to 10 is a real common age for kids to start needing glasses for nearsightedness or myopia. And I would not put a child that age in contact lenses. I don't trust them. Even my college age daughter got a corneal ulcer from probably sleeping in her contacts, and she got yelled at by her mother. Um, so no, I wouldn't consider contacts as an option for a 7-year-old. Glasses would be the only treatment for myopia at that point. Um, Glasses don't slow down the progression. They just help the child see better. So the only thing that we know of that will slow down the progression at this point is the atropine eye drops, so low dose atropine, 0.01%, 0.02%, up to 0.05%. And those low dose drops don't usually that doesn't cause blurry vision, um, and have been shown to be effective, not for everybody, of course, but they've been shown to be effective to slowing down the progression. But back to the 7-year-old, a minus 0.25 is not, I wouldn't do glasses for that. It, whether you put glasses or not, it's going to get worse. And she's really not going to appreciate much of an improvement. Um, and glasses are not inexpensive, so I would wait a little bit longer. And at 7, when you're nearsighted, you can see everything up close, so she can do just fine in school. And minus a quarter, minus a half isn't enough to degrade her vision to see the board either. So I would wait. Just follow her every 6 months and see what's going on. Um,
Sophia, did you want to jump on and ask, or are you good? She also put in the chat, both parents have very high prescription. She has
uh,
-700,
Negative
plus
what?
moderate astigmatism. The optometrist said the spectacle lens is a new special glasses for treatment.
There is such a thing as defocusing lenses, and that's an optometric thing, and I know nothing about that. So I can't really address if they're using defocusing lenses to try to slow down the myopia. I haven't seen any articles talking about that, so I really don't know anything about it. Um, I still think that minus a quarter is it's not going to help much. And they're not, the glasses are expensive. Um, but if both parents are highly myopic, the child's going to be myopic too. So it's going to happen eventually. And I'm not sure that the defocusing glasses can prevent that from happening. Um,
She says, okay, thank
ooh,
you. Yes, it's a
oh,
thousand dollars plus.
oh God. Yeah. You may come to that eventually, but I'd hold off for now. If she's a -1, think in terms, that means that her far point is still 10 feet away. So she could still see the board. She's not going to have any trouble. Now, if she's playing softball or tennis, that could be an issue. But for minus a quarter, minus a half, that shouldn't be affecting her activities at all. But it's going to change. It's going to get worse. So.
Well, we're almost at 5 o'clock. Does anyone else have any other questions before we sign off? Excellent. Well, thank you so much for everyone for joining us. Dr. Rosales, again, every time I listen to you speak, I always learn something. And, you know, I mean, astigmatism, myopia, hyperopia, they're things that are very common when we're in the eye exam, and just knowing a little bit more about that and the conditions have been really helpful for me. I'm sure for everyone on the call as well. So thank you, everybody. Have a wonderful evening.
Easter.
And
Well, Easter and Passover. Today's Passover. So.
Excellent.
Passover.
All right, everyone, we'll see you the first Wednesday of every month from 4 to 5 and more to come. I know Janice is going to be talking about bullying. We have other things coming up, other different topics. So reach out. And if you guys would like to ask for topics, let us know and we'll definitely get it on our list. Okay,
And
everyone.
Elvira, if you have a second, Elvira, if you can hear me, would you be
Yes.
able to tell us the first name and last name of your child?
Jonathan Velasquez?
Jonathan Velasquez.
Yes.